Hi, everyone. Thank you so much for being here. I'm Kara Baskin with the Boston Globe, and I'd love to give my panelists a chance to briefly introduce themselves, and then we're going to talk about something very important, the future of GLP-1s. Hi.
Hi, I'm Caroline Apovian. I am the co-director of the Center for Weight Management and Wellness at Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. And I see an Olympian in our audience, so I'm so excited.
Oh, my goodness.
Tenley Albright is here.
Hello.
Sorry.
Andrew.
Good morning. Andrew Stokes, Associate Professor at the Boston University School of Public Health.
Hi, I'm Fatima Cody-Stanford. I'm an obesity medicine physician scientist at Massachusetts General Hospital and associate professor of medicine and pediatrics at Harvard Medical School. I was the person that convinced the American Medical Association to acknowledge obesity as a chronic disease. Thank you so much for being here.
Wow, 2013, Fatima Cody-Stanford.
This is an amazing lineup, so thank you all so much for being here. And let's get right to it because we don't have a ton of time. Let's start. We just talked backstage about insurance, so let's get right into that, actually.
Yes, the big news in the obesity medicine front is after all this hard work and the arrival of GLP-1 medications to help obesity medicine physicians and primary cares treat obesity in the United States, with 42% of Americans having a BMI over 30. We have heard now in Massachusetts, at least, Blue Cross Blue Shield is stopping coverage for GLP-1 medications as of January 1st, 2026. Harvard Pilgrim has followed suit, and now MGB Health Plan also, and we're waiting to hear from others. So far, Mass Health is still on board with covering Zepbound after you trial an older medication like phentermine. But this is disappointing, to say the least. And we understand that insurance companies are having trouble with their budgets. No one is looking at the long-term decrease in healthcare costs that definitely will happen when we treat obesity as a disease and we help patients lose weight and keep it off.
What do you foresee happening in the short to medium term? I don't want to cut you off, but I just wonder
I
what's
think
gonna
this is
happen
a
in
really
January.
important issue. I saw patients all day yesterday, and instead of me being able to focus on their health care and healthcare outcomes, my focus during all of their visits was losing coverage. Many of these patients have lost between 15 to 20% of their total body weight. And it's not just the body weight itself. We're talking about the 229 obesity-related comorbid conditions associated with their body weight that we're seeing improve. When we pull back these medications, we see that about 85 to 90% of these patients will regain their weight, and we will see a reemergence of these comorbid conditions. We've seen this happen specifically with individuals that have Medicare and they switch off these medications and move over to Medicare. We know Medicare does not cover these medications for the treatment of overweight and obesity. So we see this happen with that key demographic. So instead of me being able to focus on how are these patients doing and as it relates to these issues yesterday, I spent their entire visit talking about what happens when they lose coverage. And so what are the demographics? I felt like for those of you who are old enough, I'm a Gen Xer and there's a lot of boomers in the crowd. So I'm going to take you guys back to that, those kind of brown tape recorders you used to have in the library and you press the button. And I had a tape recorder. I wish I had a tape recorder yesterday. So these people can go to a cash pay option with like Lilly, where they pay $500 a month to go onto these medications, or use a GoodRx card and use I guess a $500 cash pay option for semaglutide or tirzepatide. But let's talk about the reality, particularly in this current climate of people losing jobs and not having security to pay that exorbitant fee. For the people on this stage, maybe we will be able to handle that fee. But for the reality, for most Americans, can they pay $500 a month to cover this cost consistently? And the answer is no. And so I think that this is really a travesty when we talk about this.
So obesity is a disease. And the reason why I say forever is because when your doctor puts you on an antihypertensive for blood pressure, lisinopril, you know you're going to take it forever because hypertension is a disease. People still think, providers, the general public still believe that you can, go on a diet and exercise plan, lose the weight and keep it off. we know it's a disease.
One thing that was interesting when we talked a couple of weeks ago that I would love to learn more about, and I will say right now, I'm on Zepbound and I take Blue Cross, and I have Blue Cross Blue Shield. So January 1st, 2026, I will be budgeting, I guess, for that. But what is it that makes some folks really respond very well to these drugs, and other people, it's more multifactorial? It's not as simple as just taking an injection and losing weight.
It's not really simple. These medications, what they do is they work in the gut and in the brain, and in the
Yeah.
brain they really alter your taste, your attraction to certain foods. And what we think is happening is that the ultra processed foods and the high sugar, high fat foods that you were attracted to, that you were addicted to, even the reward pathway allows those addictions to go away, and you start eating healthier food. Diet and exercise is always important. Why some people don't respond to GLP-1s is probably the genetics of obesity, and we still don't have a good handle on all of the different genetic mutations that go into allowing somebody in this environment to gain a lot of weight. But we know the prevalence of obesity has increased fourfold since 1960. So most of us have those thrifty genes that allow us to gain weight in this environment. And I just got Kevin Hall's book, Food Intelligence, last night in the mail. I started reading it, and he talks about how the human body is in tune with the earth, with our environment, and we have all started to, our brains know what's out there for food, and we're all, most of us are gaining weight because there's a lot of high calorie food around. And it's also, and the food industry and industrialization has caused this. And we're going to end up with the entire world with global warming and the food industry and our human bodies being affected by all of this technology. And we have medication that is now
Yeah.
helping.
Right. So where do we go from here on January 1st? What do you see happening?
I think that you're going to see a lot of patients have significant weight regain. I mean, I think that the exorbitant price of these medications here in the US compared to our counterparts in the UK or Canada, where they have single payer systems where they've been able to negotiate a much cheaper price for these drugs, is such that we'll see significant weight regain, and we'll see reemergence of chronic diseases that we've been able to treat. And I think this speaks to pharma needing to make some changes in terms of pricing here in the United States. I want to bring Andrew into the conversation,
Yeah.
specifically as we talk about these policy
Thank you.
issues. And I really think we should be thoughtful about what we're seeing around the world in terms of the landscape of the pricing structure of comparing the US market, where these drugs can be tenfold the price of what we see in our neighboring countries like Canada, for example. So I'd love to
Well,
hear your thoughts.
Andrew, I was going to get there because
Yeah.
we just got a question on my iPad from the audience that says, do you think we will see regulatory change, new laws to force insurers to cover GLP-1 treatments?
Yeah, so I think, from a public and population health perspective, we've seen a mortality crisis in the United States and other high-income countries since 2010. Mortality, particularly from cardiometabolic causes, has really stagnated and increased. And I think this is going to force a reckoning in looking at these kind of broad population trends that we need to address the burden of cardiometabolic diseases and its risk factors. And I think it's just a real issue that there are certain populations that have a great deal of unmet need right now. If you have diabetes, let's say, you may have access through existing programs. But if you are living with obesity without diabetes or other major comorbidities, it's very difficult to get these drugs. So there's a huge amount of unmet need. And the people who really need these drugs the most are not currently getting them.
This is actually an interesting question, and I have so many questions of my own, but I want to get this one in, and this is, do you see GLP-1s as being a way of life, like you will be on it indefinitely, versus lifestyle modifications? Are you promoting both. Maybe promoting isn't quite the right word, but that's the
So
question.
I don't see this as an either or situation.
Yeah.
I think these are complementary. If we look at even some of the recent guidelines, including ones that I've written, we have to recognize that these should be coupled together. We don't put patients on GLP-1s with the idea that these patients will not be doing lifestyle modifications. And I also think that question exhibits extreme forms of weight bias and stigma. It assumes that persons that carry excess adiposity have not engaged in lifestyle modification and physical activity. I can tell you many of the patients that come into me have been engaging in these behaviors, but their bodies have not been responsive in the way that someone who carries a leaner phenotype like myself have been responsive to those. And so I want you to check your bias and stigma at the door and not assume that those persons have not been engaging in those behaviors, but unfortunately, their bodies have not been responsive in the way that someone that carries a leaner phenotype have been. So just want to make sure that that's
a
apparent.
very good point, Fatima, because patients who have obesity have such stigma. They naturally think it's somehow their fault, when it's really the fault of our environment. We have an environment that almost makes you eat ultra processed food no matter what happens. And that is the problem. Our brains and our genetics, epigenetics, have interacted with our environment to allow those of us who have those genes to store fat, to store calories when calories are readily available, are doing so. And our hormones, there are hormones that are secreted when we try to lose weight with diet and exercise that almost make us gain it back. It's a disease. Those of us who have it know it. It's not a matter of willpower.
I have a question about that, actually. As a perimenopausal woman who hit a wall after I had
Yeah.
two 10-pound children, I'm solidly in my mid-40s. I was always very thin. I turned a certain age, I had 2 kids, and that stopped being the case. And in fact, I felt like I put on weight almost without thinking about it. Did I always have obesity? And I don't mean quotes like it's not a real thing, but was this always, for those of us, and I know many of us are in the same boat as me, or is it something that can develop over time? Or are we always predisposed?
No,
Was this always going to happen?
there's different triggers, right? There's
Okay.
over 100 different causes. Particularly in women's lives, there's 3 different times where we can see transitions. The transition of the onset of menses, right? So menarche, pregnancy, for example, can be a major shift. And then the perimenopausal transition, where we have a decline in estradiol and a shift of more visceral adiposity accumulation that happens. And so that's a major trigger for women developing excess adipose or fat storage. And so it's different triggers. For some people, it may be going on certain medications. We know that there are certain obesogenic or weight promoting medications that may trigger. And so we have to realize that there's different triggers for different people. A lot of times we hyper focus on food and ultra processed foods, but not all ultra processed foods are necessarily deleterious to our health. This is something that we struggled with as a member of the Dietary Guidelines Advisory Committee. We came back and said there was limited evidence. Let's think about things that we eat that are ultra processed that potentially might be good for you. I'm going to throw out a name brand, Kashi. When you think Kashi, you think healthy. All Kashi materials are ultra processed. All cereal is ultra processed, but we categorize all ultra processed as anything that's not found in its natural form. So we have to think about ultra processed as a category and recognize that some things in that category may be more beneficial to us than other things within that category. So we just have to be aware that it's not all one thing that's triggering obesity, i.e. food and food categories. It could be trauma, a static load, stress and stressors. So we have to recognize that there's different things that can contribute to someone developing obesity at different times in life. There are some people that come in through with strong genetic loading. As a pediatrician, I see people that come into my office at the age of 2 that are already at the 180th percentile of the 95th percentile with regards to obesity. I'll fly into the American Academy of Pediatrics meeting in Denver tomorrow, and we'll discuss persons that have that strong genetic loading. So we have to recognize that different people are predisposed that have that strong genetic loading, and then other people may develop obesity from other triggers later in life. So, for example, that menopausal transition that
That's me.
really is, something that affects people, and it's why the number one person that seeks weight management, whether it's in the form of lifestyle, pharmacotherapy, or metabolic and bariatric surgery, is going to be a peri or postmenopausal white woman.
This actually raises an interesting question, and this is a personalized approach to Ozempic or other such drugs something that we might see in the future? So let's say, could somebody come to your office who is predisposed to obesity from the time they're very young? Might their medication needs eventually be tailored differently versus, say, a woman like me who had, hit perimenopause and nothing would move the needle? Will we be able to target with precision medicine these
Well,
drugs?
when we have a better handle on the genetics,
Yeah.
certainly when Fatima talks about the triggers, they are hormonal triggers. Let's be clear about that. And male triggers are also hormonally related. Loss of testosterone as you get older, sarcopenia from that. It's all hormonal. So, but not all of us have those triggers, right? So, yes, we have to develop a personalized approach to to treating patients with lifestyle plus medication. And the medications right now, the two that we have on the market, they are dosed at a certain level because of the the pharma companies dosing them in pens. Eventually, we hope when generics come out that the doctor in concert with the patient will develop the dosing schedule for that patient as a more personalized medicine approach. But let's also talk about obesity as a whole. Now, the Lancet Commission, which Fatima was a part of, came out and strongly suggested that we find a better measure of obesity than the BMI,
Which is flawed.
which is flawed because we can't measure body composition very readily. So, but until that time, we have the BMI, and we can categorize obesity, mild, moderate, severe. Severe obesity, certainly BMI over 40, over 35 with diabetes or sleep apnea. We have a multidisciplinary approach to treating obesity, which includes metabolic surgery. We don't do enough of these procedures in the United States per year. We have 14 million Americans who have a BMI over 40, and we only do 250,000 procedures per year. The sleeve gastrectomy, less than an hour in the operating room, you're out of the hospital in one night, you lose 80 to 100 pounds, 25% of your body weight over the next year, and for the most part, you keep it off without the need of medication.
Why aren't we doing more of them? Are they not covered?
They're covered.
What's
They're covered. So it's the stigma of the procedure and the stigma of obesity. I have patients who clearly would benefit, patients with BMIs in the 50s and 60s who come in, and I talk to them about metabolic surgery, and they don't want the easy way out. Unbelievably, that's not the easy way out. They feel they can do it on their own. These are the and then they know so and so who gained all the weight back. Well, if you have a stent placed or a cabbage for heart disease, you don't say, "Oh, I know so and so who re-stenosed," right? This is the same idea.
And on a national level, when we look at the claims data, GLP-1s are now supplanting almost everything else. The evidence that we have to date shows that sleeve gastrectomy and other surgical procedures are going down. Behavioral and lifestyle support, counseling is going down. And so we really worry about these substitution effects and the lack of a multimodal approach.
So that's interesting. So people don't feel the stigma around doing Ozempic or Zepbound, but surgery is a step too far. I know so many people who are on these drugs and say, please don't tell anybody. But, and I get it, but people do feel funny about it.
Yeah, so it's the stigma.
Yeah.
That's what the problem is.
How do we fix that?
Education. Education and more education.
I think a lot of this goes back to the Biggest Loser phenomenon. And for those of you who've recently seen the Biggest Loser documentary, which was tragic, demeaning, demoralizing, I can't think of enough adjectives right now to explain how we could contextualize that phenomenon of individuals that have obesity deserve their fate. They have brought this upon themselves, and so they don't deserve this thin world, this idea of thin privilege that I've really thought about, this idea that you don't deserve what I have, which is living in a thinner body. You must work for it, and if you don't do the things that were in that documentary, and this is spoiler alert, so cover your eyes or ears and all of the things if you don't want to listen to it, but you need to work for it. You need to work out for 9 hours a day. You need to subject yourself to eating less than 500 calories a day. But what you didn't see in The Biggest Loser was ever a reunion show. And why didn't you see a reunion show? Because those patients regained their weight. Because they're this idea or concept of metabolic adaptation. You come back to where you were prior to the initiation of this really inhumane treatment of those contestants. What we're talking about is long-term therapy in the form of lifestyle modification, pharmacotherapy, surgical intervention, or a combination thereof for the persons that need it, and then tailoring the therapy to the person that's in front of us. And that's the work that needs to be done, and recognizing that it's not a one-size-fits-all therapy for individuals. When I'm treating patients, I realize that from patient to patient, I'm going to need to tailor the therapy to the person in front of me based upon what brought them in and what they're going to need to sustain their care. Most of my patients have been with me for at least 10 plus years. And so when people are like, oh, well, I've done this and this worked for me for 6 months, I am not impressed. Oh, this happened for a year. I'm still not impressed. Give me the 10-year story. Give me the 20-year story. Then we can talk about being impressed, because this is a chronic disease. And we need to be thinking about interventions, sustainability, policy measures that are going to work over the long term.
It reminds me a bit about the conversation around mental health, something that I'm also very involved with. And, it's not so simple as just, oh, be happy, look on the bright side. I take Prozac. I also go to therapy. I also, it's not just one thing.
Right.
It's not just taking a pill. One interesting question in terms of stigma and reducing the stigma is from an audience member who says, couldn't classifying obesity as a disease in itself cause stigma? In other words, what is the role of the body positivity movement in this discussion? So
I think that you can still be positive about your body. You can still think great things about who you are. My patients still leave the office feeling good about who they are. But why not recognize that there's pathophysiology of the disease? I'm not going to demean them and treat them lesser than who they are, or put up a picture and say, oh, you were not a good person when you came into me at 413 pounds, like my patient, that was my patient that yesterday that's now down to 230, and oh, now you're a good person. That's what being not body positive is. I acknowledge him for who he was and his value and worth at 413 pounds, and still acknowledge him for who he is at 230 pounds. And that's where we have gotten this situation flawed.
what happens next? So January, I know I asked this in a slightly different way earlier, but I'm thinking of all of the people watching thinking, I'm going to lose my coverage in January. Not everybody is going to be able to pay $499 or whatever. I'll stop I'll scrim somewhere and make it work. Not everybody can. What are you going to start doing? What do you think needs to change to make this a lasting, sustainable conversation where people have access to the drugs, the surgery, the mainstream conversations about this? What has to happen?
Yeah, on one level, these are miracle drugs, and there needs to be outrage, and there needs to be a grassroots movement. We've seen in the past, like with ACT UP, that there was mobilization around antiretroviral therapies for HIV,
Right.
and that worked to expand access around the world.
Mhm.
And we need a similar level of outrage about these drugs, which are highly effective and are not reaching the people that need them the most.
Yeah, I think it's all going to happen at once, right? January 1, all the insurance companies are
Right.
going to stop coverage. Everybody has to get out there and fight. The public, doctors, the government, communities, we all have to fight against this because people are going to regain the weight quickly, because that's how, when your body thinks it's starving to death, suddenly, because you don't have the GLP-1s, your hunger is going to come back rapidly.
Oh, I went off for a week and I felt it.
Yeah.
Yeah.
So, and you can't help it. You
No.
overeat because your body thinks it's starving. So bad things are going to start happening.
When you say fight, is it writing to your insurance company? What does that look like for just people like me?
Yes, writing to your insurance company, writing to your, going on the Hill, writing to your congressman. What else can we do?
I think it's social media campaigns. I think that, it's using the social media networks that we have. We didn't have these before, but if it's leveraging these large grassroots campaigns in a public sphere that allow us to get our voices out there.
In the end, the pharma companies are going to have to do something,
Right.
or else they're.
Well, you mentioned generics. What's going to happen? Is that something that could be?
That's not quite, we're not quite there yet.
Not there yet.
Yeah.
We
Okay.
can say compounding drugs, that the FDA is going to call them GRAS, generally regarded as safe. So, in the end, maybe if we can feel safe about it, we will tell patients, go out there and look for a registered pharmacy and get it compounded.
I know a lot of people who go to like Hers or Hims or whatever those platforms are.
Absolutely not.
Okay.
Absolutely not. Okay.
Why is that dangerous? I think that's important.
Yeah, I think that's a really important point. I didn't know we were going to go there.
Obviously, it's controversial.
I think that we have to go as scientists. We're here at Harvard Medical School today. We have to go with what's been studied, what's been proven. If we have head-to-head trials with something, for example, semaglutide under the trade name of Ozempic, Wegovy, tirzepatide under the trade name of Mounjaro, Zepbound, and we have head-to-head trials that demonstrate similar levels of efficacy and their safety profile, then that's one thing. We have zero data to support the use of these medications. And until we have data, I will not feel comfortable sending my patients down that road.
I'm glad that we touched on that because I do know a lot of people who do it. We are out of time. I knew it would go so fast. Thank you all so much for being here.
Thank you for being such a great moderator.
Of course.
Thanks.